Welcome to Hidden Conversations. Hidden Conversations is coordinated by WVIK and hosted by Dr. LaDrina Wilson, a leadership and diversity expert. These conversations are designed to delve into many of the most difficult topics of race and equity facing the Quad Cities today. Many of these issues we hear about every day on the news, but we are often left unaware when they occur to our own friends and neighbors. We hope that by hearing firsthand stories and statistics from experts based right here in the Quad Cities, we can break down the myth that these issues only happen in other places, and in so doing, increase our empathy for those who literally live right next door. Thank you for joining us this evening. And now, here's Dr. LaDrina Wilson.
Hello. Thank you so much for joining us for this conversation today. So excited to have all of you. I'd also like to extend a special thank you to our guest, Dr. Tiffany Stoner-Harris, a licensed mental health counselor at Three Daughters Strong Hearts Counseling, Ebonie Baily from Naturally Ebonie Doula Services, who serves as a doula and also the co-founder of Iowa Black Doula Collective. And last but not least, Daniel Joyner, the Diversity Community Impact Officer with Unity Point. So excited to dig into this conversation today. I want to remind you, the audience, that this is a conversation intended to be both intimate, but also to challenge the status quo. So we invite you to participate in this conversation as best as you can. You are able to provide comments there through the Facebook feed, and we will pull some of those questions as they come in to allow you to engage in the conversation. But before we go any further, I want to kind of ground this conversation related to inequities in healthcare from a historical perspective, but I also want to personalize it to a Quad City perspective. So just bear with me. I want to share a little bit of information with you before we turn it over to our real experts here. In 1926, syphilis was considered to be a major health problem in the United States. 35% of the reproductive age population actually had syphilis, and that's across all demographics. In 1932, following the Great Depression, there were 399 Black men who were entered into an unfunded study that was approved by the government, known as the Tuskegee experiment. And as a result of that study, those 399 men were seen monthly and provided annual treatment. They thought they were being treated for syphilis and thought they were being cured of syphilis, when in fact, those 399 Black men were never treated for syphilis. In 1945, syphilis was approved to be treated with penicillin, and the study continued until 1972. Now, I'll leave it to you to do your own research about the various stages of syphilis and what it does to a person's body when it goes untreated. But these Black men that were participants in the Tuskegee experiment were unknowingly guinea pigs, and it was approved to be studied in that way. And some might say, well, that was 100 years ago. What does that have to do with now? We've made a lot of progress, and I would agree with that. But I also like to offer you another example. In 1951, Henrietta Lacks was she was actually a woman who was seen and treated for cervical cancer. She didn't know it was cervical cancer at the time. She visited her doctor, and she presented with vaginal bleeding. They did a biopsy. That biopsy was then used by Johns Hopkins and University and several others. And Henrietta is actually attributed for the treatments that we know today for the first round of vaccines for polio, because her genomes duplicated at a rate that was never seen before. And so her family was not aware, though Henrietta died in October of 1951, they were not made aware until 2010 that this African-American woman's genomes were being made available to the public, that pharmaceutical companies and research companies were profiting off of her genomes that were curing people all over this country. So she's made significant and major contributions, but her family, who was poor, didn't reap the benefits of that from a financial perspective. Now, in 2013, the matter was somewhat rectified. The Supreme Court indicated that you couldn't patent genomes, you couldn't patent that information. So no one was going to make a profit off of it. The family wasn't going to be paid any financial restitution, but they did have an opportunity to have a seat at the table and make decisions about who had access to their genomes. So there was a biomedical ethical situation that was happening there. And still some might say, well, does that really matter? Again, that was 1951, and they've since addressed that issue, and it's been rectified. To that, I would point you to a study from 2006, and 2016, and that study comes from the proceedings of National Academy of Science in the United States of America. And what that study looked at was racial bias in assessments of pain and pain treatment. And what that study found was that it examined first-year students, first, second, third year, and resident students. And what it found was that there were some medical students who in 2016 would now be doctors today, and residents who are now practicing today, still ascribe to beliefs that Black people age differently, slower than white folks, their white counterparts, that Black people have thicker skin than their white counterparts, all of which are just biologically not true. There were a wide variety of biases or beliefs that were even presented as part of this study. And I share that because the outcome showed that most often Blacks were pain was underestimated, and therefore they were treated with less medication that would typically be prescribed for the symptoms and diagnoses that they were presented with. Conversely, white people were given more medication than maybe was needed as a result of their pain indicators and the perceptions of those doctors. And that includes opioids. And we understand what's happening in our country as it relates to the opioid crisis. So when I say to you, this is a historical perspective and try to pull things into a current context, I want you to understand that when we have disparities and we're not addressing them, all populations are impacted. So we really need to be examining these things. And I'd like to just provide one more story before I turn things over to our experts. So for those of you who say, Tuskegee was 100 years ago, and thank you, Mrs. Locke, for all you've done for our community. And yeah, that was a group of medical students. I'd like to point to a situation I experienced about a year ago with my daughter here in this community, where she presented with, I won't go into her personal information, but she had a medical issue that resulted in her experiencing a lot of pain. They had suspicions of what the issue was, but weren't going to treat it just yet. And I'm fortunate to have a few nurses who are friends and family who I had discussions with, who said, so they're not going to treat her even though they have a strong suspicion and she's experiencing a lot of pain. And the treatment that would be prescribed wouldn't cause her any negative side effects. And I said, no, they said they weren't. But I didn't push because, and I don't recommend you do this at home, but I had a prescription that would give her relief. And I gave that to her and it gave her relief. Several weeks later, when we found out what the issue was, she still wasn't prescribed the medication that was needed to give her relief as part of her treatment. Again, my friend says, I'm just shocked that they're not giving her what she needs as part of her treatment. And I didn't take up the issue with my friend at that time because when these things happen, we experience them and we don't necessarily want to jump to the conclusion that it's race related, particularly when maybe you're dealing with a friend who comes from a different racial or ethnic background. But I already had the suspicion because I know the data and I know that whether those biases are there implicit or explicit, this is the experience of many Blacks when we are treated in a healthcare setting. Now, I've had plenty of great experiences in our community, but I think it's important that we ground this conversation of what's happening here in our own community. And these are real life experiences that people have. So with that, I want to let you know that today's conversation is really about examining some of the disparities, but ultimately we want to work towards solutions and figure out how we can be a part of the solution. So without any further ado, I'm going to turn things over. I'm going to start with Ebonie, because I'm sure there's a couple of folks who are on the line and online with us wondering what the heck is a doula anyway. Perhaps they were doing a feverish Google search before we went live. And so Ebonie, if you would share with us why you decided to go into the field that you're in, what were some of the things that you've either experienced or witnessed that influenced your choice to be a doula?
Definitely. So let me start with, what is a doula? A doula is, doesn't have to be a woman. It could be a man or a woman, but someone who provides, a professional who provides physical, emotional, and informational support before, during, and after labor. So oftentimes a doula will know you better than your provider will even know you, because you meet with your provider during pregnancy 12 times potentially. I'm the person that you're calling when you're like, hey, my stomach hurts, my toe hurts, my ankle hurts, something is wrong, can you help me? And I am not a medical professional at all, in the aspect I'm not prescribing any medicines, I'm not telling you to take any certain vitamins, anything like that. What I will do is say, hey, refer to your provider and ask them these questions. So my job before labor is to have my client be prepared mentally, physically, emotionally, be empowered, be ready for the task of labor. So I provide a number of checklists and questions for you to ask your doctor. You only know what you know. And so if you go into things ill-informed, then oftentimes things happen to you and not necessarily for you. So that is my role as a doula. I have been a doula for 3 years now. I trained through Doula International. Now, little back history of kind of how it all started. Birth work is, I feel like, has always been in my bones. I've always been the mom of the group. But in 2010, my best friend was pregnant. She was here in the Quad Cities, had an OB. We had both done research. We were pregnant at the same time. And when she went into labor, she was laboring for a while, had been coming on close to 24 hours. Her provider would come in and check on her, and he was just kind of overly aggressive, not asking for consent before he was wanting to do exams. We had already created a birth plan, so he was well aware, had signed the birth plan, that she didn't want an extreme amount of exams. And he just kind of was very pushy and like overriding that. So at some point, it had been about 23 hours that she had been laboring, and he comes in and he's like, hey, listen, it's almost 24 hours. If you got a couple hours to get this baby out before we're going to give you a C-section. And she was exhausted. And I'm like, C-section? Like, what are you talking about? Is something wrong? And he said, well, no, the baby's doing fine. Heart rate is fine. Oh, okay. Well, why are we suggesting a C-section? And he says, well, she's just been laboring for a long time, and I can tell that she's tired. And we just, I'm going to give you a couple hours, but after that, it's going to be an emergency C-section. And I'm like, wait a second. So we went from a birth plan that says no cesarean to a couple hours, we're going to do a cesarean, to now an emergency, all within a 5-minute conversation. This is not okay. Why are you pushing this so aggressively? Later found out that he was actually leaving for a vacation later that day. So that's why he was pushing so aggressively. Me being kind of just new in certain aspects of the birth world. I'd had a child myself by that time. I was at a loss. What do I do? How do I protect her? How do I make sure that her wishes are protected? And I laid over her, physically laid over her, and was like, you're going to have to cut through both of us. And I'm crying. She's crying. He calls security, and I'm like, what do I do? Luckily, my sister actually worked for the hospital. So she had some connections. We made some phone calls, had a conversation with the provider, and he was like, you're lucky I don't kick you out of the room. And I'm like, great, whatever. She had her baby a couple hours later, and all was good. We never saw him again. Switched before she had to go to her 6-week checkup. But it was at that moment that I recognized how much trauma could be created during that time period. This is the time period where you are the most vulnerable, where it's supposed to be sacred. You only get this childbirth experience, of course, one time per child, right? And so to think that for forever, I have this trauma that I now need to deal with, and this provider is just moving on to the next room as if nothing ever happened, hit me. And I thought, what can I do differently? How do I get involved? How do I help other women? And so after that, I started helping other women, but I, at the time, didn't know what a doula was. So years later, took the training, and very thankful that I did. Love what I do. And it's important to have someone there who can advocate for you and oftentimes give you the courage to speak up when you don't have the strength.
One of the things that was really striking about kind of your background is the network that the collective that you've created for Black doulas. And one of the questions that I want to pose to you, Daniel, is do you, from your perspective, are Blacks well represented in the healthcare industry in our particular area, and even in psychology or counseling, whether it's healthcare administration, doulas? Are there Black professionals working in the space at a proportionate rate, and does that even matter?
Thank you for the question. So I would say our community, makeup of our community here in the Quad Cities, and the healthcare workers that we have here in the Quad Cities is actually pretty representative. Where you start to see the disparities take place are exactly what you're talking about in professional positions. We typically see the diversity within our frontline team members, our entry-level positions, our food nutrition services positions, our environmental services positions. But when we get into our nursing, medical providers, that's where you start to see the disconnect there. And it's extremely important. To Ebonie's point, having someone there advocating for you, and also who looks like you, who shares a similar experience that you share, is extremely important when you're trusting someone care that they're providing for you or for your family, right? I'll give you an example. My mother, who doesn't live in the Quad Cities, travels an hour from her house to go see her primary care doctor because he's a Black doctor. And when I asked her why, you have a ton of providers in your community that can provide high quality care where she lives, and she said it's because he understands where I'm coming from a cultural perspective. So there's an automatic connection there that's made. I'll share another story. We had an event last year where we talked about breast cancer and cervical cancer, specifically in the Black community. We had close to 300 Black women here in the Quad Cities attend that event. And one of our Black YN providers presented at that event. And I couldn't tell you how many times, of course, I was the only guy in the room, so I got called out for that. But I don't know how many times people came up to me after that event and said, I didn't know we had a Black GYN doctor in the Quad Cities. I'm changing doctors. So I can see that provider. So it's extremely important to have representation reflective of our community, so our community members feel comfortable with the care and welcome with the care that they're receiving.
Yeah. Now, I realize that we've talked a little bit about trauma as a result of some of these experiences. I think, my stories that I have shared, I knew about the Tuskegee experiment at the age of 10. I know there was a movie released probably when I was maybe 12 or 13. And while those stories are not necessarily specific to my family, it is part of our history, right? It's part of American history, and it's very specific to the Black experience. And so when you talk about trauma or only knowing what you know, right, and not maybe being informed, how does that translate to how people potentially access mental health services or have an understanding of wellness as it relates to brain wellness? I think that's probably best for you, Dr. Stoner-Harris.
I wasn't sure. The thing I think about with brain wellness and, as a clinician is, and especially as you talk about some of the historical context is, as providers, we have to recognize the transgenerational piece of trauma. And so we're not just looking at present day trauma, we're also looking at the, historical implications of trauma and how that might impact clients' willingness or lack of, clients and patients' willingness or lack of willingness to come into a setting that, historically hasn't been fair, hasn't provided, as you talk about, whether it be, the implications for pain management or implications for studies that targeted African Americans, Black communities in a way that wasn't in our best interest. It has created a barrier in itself in terms of people not trusting the medical profession. And, and that's from, with physical illnesses to mental illnesses. There have been some barriers created due to that historical piece. And so we have to acknowledge that as we start to think about, what is it we need to do to eliminate some of those barriers. First we have to acknowledge the reality of that historical context and the impact that it has had on generations and generations of people. And so, we can't just do the minimal and expect that people will walk in, with open arms. They have to feel comfortable, feel safe, see providers who look like them, and come into a space where they feel like they're heard. And so when they're talking about their symptoms, their symptoms need to be acknowledged as the client or patient is sharing their symptoms, not as the professional wants to hear them, or, their voice needs to have, I think of it as a collaborative, even though you're the professional, you have the training, you have the education, people are the professionals of their lives. They know their bodies, they know their symptoms, they know, when they're not feeling their best. And so we have to be willing to treat people as if they are the professionals and collaborate with them and again, make the space safe. If people, if a client or patient has had a history of trauma and walk into a setting that doesn't feel safe, they could be re-traumatized by their provider and not come back for services, whatever those services are, if they're, mental health related or physical health related. And so those are all things that we have to keep in mind when we're thinking about the barriers and trying to eliminate the barriers is, what does this person need to feel safe? And, we know that in the Quad Cities, we don't have a diverse group of providers, whether you're talking about physical health or mental health. And so are we appropriately training and providing training for the, white clinicians or non-Black clinicians or, or medical professionals that are in the Quad Cities? Are they required? Are they receiving adequate training to understand the historical context, the cultural context, the genetic context, what's different for African Americans, Black populations than other populations in terms of, I think about from a mental health perspective, psychotropic medications. You can't treat every client, whether they have the same diagnosis or not. You have to think about their racial and ethnic differences. And, a lot of the, for the mental health field, a lot of the studies conducted are not conducted on African Americans and Black populations, yet the treatments are applied in the same way, as if they will be as effective.
Well, and I think that ties into the historical perspective, right? Mm-hmm. So if you look at, if we had a historic moment where people were in a study not being treated, thought being treated, right? And we don't always know the history that's passed down, but for those who do, you are sensitive to that. So I may be less likely to be a guinea pig, because are you really going to, even if I participate in this trial, even if I'm financially compensated, are you really going to do what you say you're going to do? I think the other thing, and I want to make sure I correct this, it's Henrietta Lacks. So Henrietta Lacks was the individual that I think I said Lacks. For her family, a perfect example would be what they did with her biopsy, with her genomes. I personally won't do the Ancestry 123 or DNA me and all these different things, because I'm like, I don't know what they're going to do with my information. And it's about trust, right? Like, we're foundationally talking about trust, or lack thereof, I should say, in some instances, right?
Yeah, so if I can jump in here real quick, I think it is something that we as Black individuals in our community all feel, right? I remember growing up, my parents telling me when we go to the doctor, don't share any information that's not related to the visit and the reason why we're here. So when they're asking us questions about our family history of diabetes or heart disease, or has anyone experienced a stroke in your family, we were quick to answer no, because we didn't know or had some level of distrust in what they were doing with the information. So I agree. I think it goes further than just that initial interaction with a provider or a medical team. When we talk about some of these things, and how do we educate our medical professionals on some of those realities that the Black community may not be comfortable sharing their family history within the first visit and first 5 minutes of meeting you. It may take time to get there with us, and you need to be on board and ready and willing to be patient with that.
And I think that what goes along with that, so one thing that I teach my kids is to speak up for yourself. I don't want you to ever be in a position to where you are afraid to say something to your provider. So when we go in, don't ask me what their names are, ask them. They're your patient, not me. And they need to know now at the age of 3 and 4 to speak up and how to say whatever it is, what's hurting. Ask your patient, don't ask me, because I don't want my kids to grow up and feel intimidated by providers.
Yeah. And then I think you see the other piece with that too, when we talk about providing care in our community, is compliance, right? So, looking at immunizations, for example, we're starting to see a decline in the trust of vaccinations in people. Because I think of some of those historical components that you laid out at the beginning of the conversation, LaDrina, when you look at Tuskegee and not understanding what are you doing and what trials might you be running on the side when you're saying you're providing a type of care, I think it adds to the overall trust of us as medical providers in our community.
So that's obviously a barrier, right? That particular issue around trust, but I imagine there are other barriers. Ebonie, you've kind of alluded to speaking up for yourself, and I'll just share a really quick story. I can remember a friend of mine telling me about how she worked in an emergency room, and the particular hospital that she was at, not in this area, but in another area, still very applicable, was in a low income area. And this ties to another question that I'm going to ask. But at the end of the day, there were a lot of racial and ethnic minorities that came through that facility. And she was talking about this woman and how she was helping her son or her nephew or something. And she was describing what had happened. And she said, and then he just fell out. He didn't passed out. And she didn't understand this. My friend's white didn't understand. As she's telling the story, I'm like, oh, he fainted. So when she said he done fell out, in me understanding the Black vernacular, I understand that he just fainted. But we can't have providers who are working in a community that's densely populated with people who don't look and maybe even act as in the same way that they behave, not have a willingness to try to adapt and expect the patient to come in and present with the vernacular that is, I mean, I wouldn't consider fainting being a clinical term, right? There's probably an actual medical term for that. But still, the point is, there's got to be some give and take. It has to be collaborative. We have to be willing to try to meet people where they're at. That goes for any field. So I don't want to imply that medical professionals are derelict in their duties in any shape, form, or fashion. But I think the lack of trust, the communication barriers, are some of the challenges that we face when it comes to these disparate impacts that we see. Are there any other barriers that you can think that are different for the Black community than maybe for other racial or ethnic groups that we haven't touched on?
About labels right away, especially from a mental health perspective, and thinking about diagnoses and, what that could mean for clients. We, as African Americans, we're already faced with so many barriers. And so, in talking to clients, whether it be child clients or adults, that fear of being labeled or even, having been in the mental health field as a client for so long, some clients will start to label themselves and it become kind of self-defeating language. And so, I think that lack of understanding of mental health and again, going back to that collaborative relationship with providers, mental health providers, and having appropriate diagnoses. I mean, that's one of the other concerns in mental health is an overreaching with diagnosis with Black and brown people versus, white people. Just the reality of, thinking about the least harmful diagnosis is one of the things that we're trained to do. And, the most appropriate, obviously, but the least harmful in terms of labels. And so, that same consideration isn't always given to Black and brown people. And so I think that is one of the barriers that keeps people from seeking treatment is the fear of having to walk around with this mental health diagnosis.
So with that in mind, I get that, having a label or either being mislabeled could definitely be an issue. Data suggests that Black folks as well as Hispanics are more likely to access their healthcare in non-optimal settings, so like emergency rooms and that type of thing. Again, you guys are the professionals, so I'll lean on you. My first inclination would say, maybe there's a healthcare access to healthcare issue. Maybe that's part of that lack of education. When people don't have that continuity in care, is that something that's real here in the Quad Cities from a statistics perspective? Daniel, maybe you can chime in on that.
Yeah, I definitely think we see a misuse of ER services here in the Quad Cities. And I agree with you. I think it's partially due to the lack of education around the importance of having a primary care provider. And people that use the ER for primary care not understand that it's not, it's called an emergency room for a reason, right? It's for emergencies. So if you have a headache or you twisted your ankle and that type of thing, those are things that can be taken care of either at primary care or express care setting at a much lower cost to the patient or the consumer. That I think more education needs to be shared with the community around that.
Is that for those accessing of those types of services and the usage of the ER, would you say it's disproportionate for Blacks in this community compared to our relative representation in this area?
Yeah, well, we definitely see that, especially when you also talk about insurance coverage as well. So those that are underinsured or uninsured, and how they access care as well. So if they don't have an established primary care provider, their chances of going to a primary care provider will be slim, right? So if they're underinsured or uninsured, a lot of times we see them present in the ER as well.
Okay. Shifting gears just a little bit, Ebonie, I want to pull you back into the conversation a little bit. There has been a lot of information shared over the past year or two related to Black women and pregnancy-related deaths. And so I wanted to talk a little bit about some information as it relates to our community. If you have information on that, what are the factors that contribute to maybe the disparities that we're currently experiencing as it relates to pregnancy-related deaths for Black women?
So there are some studies that are being done in Iowa City. And what they are finding is that a large percentage of the deaths occur because of hemorrhage, which is 99% preventable. So why are these women hemorrhaging directly after birth? Oftentimes they're still in the hospital when the hemorrhage occurs. Why is this happening? So what they have found is that either they're saying, hey, I'm cramping, not really sure what's happening, but I'm cramping. Let me call a nurse. And the nurse comes in and the nurse says, you just had a baby. You're going to cramp for a while. You're still going to feel some contractions for a while. You'll be fine. You'll be fine. And then they come back in and they're not fine. And I actually had that experience with my second. Also, what women often don't know is after you have a baby, the placenta is supposed to be examined to make sure that no chunks were left inside, no pieces of the placenta have fallen off. And I've been in births where the provider will take the placenta, toss it in the bowl, they take it out and they trash it. They weigh it and they trash it. As a patient, you should be asking to see your placenta every single time. Every single time you should make sure that it gets examined. But most women don't know that. And so then you hemorrhage and you have no idea why. And then you're having a DNC happening and you're panicking and you need a blood transfusion. So again, it's lack of knowledge. It's lack of having someone there to advocate and to kind of watch over. And so even in this study, some of the studies are the women who the people who are participating in the study or doing the study, rather, researchers are saying, hey, you should have someone in the room who can advocate for you. You need to have a doula. You need to ask questions. But a lot of these deaths are definitely preventable. And that's what's hard to swallow, is that we could have a lot more mamas alive now if we just ask the right questions or even know the right questions to ask.
So that kind of goes back to the education piece. And so when we're dealing with some of the issues related to our community and the way they impact the Black community, I really want to dig in a little bit on the kind of personal choice and personal accountability, and also examine what are maybe some of the systemic issues, right? And so I have a question, and for whoever is most comfortable answering, feel free to chime in. What do you say to the person that says we all have agency over our choices, whether we choose a healthy lifestyle, whether that's brain health or overall wellness? And if the disparities in the Black community exist, it's because of personal choices. How do you address that person?
We don't all have access. People who live in rural communities don't have access to a Whole Foods market. You know what I mean? They have access to Walmart, which may not provide the best of the best options. So I think that if you had access in a lot of cases, you would do better.
Yeah. Or they live in a food area where we call a food desert, where there's no grocery store, no Walmart at all. And your closest place to get food is a convenience store. The amount of healthy food that a convenience store sells is very slim, right? So if you're telling someone they need to eat healthier, they may have a challenge doing that based on the environment that they live in. Now, I will say, I do, and this is my personal feeling, there is some level of accountability or responsibility on the individual based on the type of foods that they eat, if they do have access to those foods, or the ability to exercise. So there is some level of responsibility. I also mentioned the compliance piece, right? So if they're prescribed blood pressure medication, for example, and they understand, the routine and how to take it, there is some level of accountability there that they need to follow in order to remain healthy. There are some issues that are out of our control that impact our health as well that we need to take into account.
Yeah, I think from a mental health perspective, access is definitely a concern. In terms of insurances, I mean, some people are dealing with this in terms of their physical health, but mental health, it's the same thing. There may be several providers in the community here in our Quad City community, but providers have, if they're independent providers, if they're in private practice, if they're in group practices, they have a choice, of what insurances they accept. And so, some providers will only accept, certain insurances, which quite often leave, a whole group of folks out of limits their choices when it comes to mental health. And so, and then when you look at the larger systems, for our community here, it's Robert Young and Vera French, there are sometimes month-long waiting lists, to get in to see some of the providers for mental health. And so it's, they can't get into some of the more independent or private practice providers, and then they can't see them at all because of the discrepancies with the insurances. And then the providers that they can see, they're often put on these long waiting lists. And so, if they don't know someone within the mental health systems, or if they haven't received treatment, in the past of some sort, they could go for a long period of time and their symptoms, increase to the point where it becomes unmanageable. And then they might show up in the ER. Yeah. So, for example, with mental health, this is quite often what happens. So, I mean, that's a systemic issue, especially with people who are dealing with some of the more chronic or severe mental illnesses that, and sometimes it does come down to a medication compliance or non-compliance issue. But, what helps with that is education and wrapping systems of support around people who may have more challenges maintaining, their medication for whatever reason. So, yeah, I mean, from a systemic perspective, those are different pieces that, can negatively impact someone dealing with the mental illness. And so from a problem solving perspective, we definitely can look at what needs to change in the system where people can actually utilize more services. For one thing, what else do we need to do as a community to bring more services, bring more providers in the area that can actually meet the mental health needs in our community?
Yeah, and to piggyback on that a little bit, just access in general to healthcare services. So, and I think this kind of speaks a little bit to the question earlier, LaDrina, about the ER utilization. So, the express care locations that we have, the primary care locations that we have, are those offices open during times where people in our community need to access them? Or are they open during the day when we're all at work and then they close, and now your only option, or one of your only options, is then going to the ER, even if it's not an emergent situation? So I think that's another thing that we have to look at. In addition to that, and we talked about providers that look like us, having providers in our community that are close by. So when we talk about transportation challenges, in some cases where, we expect someone to show up to a 15-minute doctor's visit, but by the time they hop on the bus, if they use public transportation and drive around, it could be a 4 or 5 hour day for a 15-minute appointment. So do we have providers placed strategically in our community to address community needs as well? So I think that's another access issue and access point that we need to look at.
So I would be remiss if I didn't touch on COVID. And Daniel and I have gone back and forth. He's taken a sip of his water there because I said, each time we say the COVID word.
It was supposed to be an inside joke, right?
Yeah, it's outside now. These are no longer hidden conversations. Everybody gets to hear it, right? So we had a little joke there going, but COVID is very serious. And we know that it has dramatically impacted our community and our way of life. The healthcare sector knows in particular firsthand the dramatic impacts that COVID has had on our community. And so I just want you to share with us, Daniel, how our community, particularly the Black community, compared to our white counterparts, have been impacted by COVID-19 here in the Quad Cities.
Yeah, thank you. So you've seen, I'm sure you've seen stories across the country on how COVID has impacted disproportionately communities of color. We fell victim to that as well. We have seen disparities in that, and I think it really highlighted how underserved our community is at times. And so we've seen the disproportionate rates in our community and how COVID has impacted us. And it's not that we're more susceptible to the virus in that way, but it more so speaks to what we call social determinants of health in our work. And it's really, and that means it's things that aren't directly related to providing care to an individual. So it's the jobs that they hold, housing in their environment that they live in, their income level, their education level, all of these things that impact the overall health. So I'll share an example with you. If you have a bus driver that's in our community, you know, they're interacting with people a lot throughout the day, right? Which increases your exposure to potentially contracting COVID. You take that home then to a household that may have 10 people in it, and now you have increased the exposure to your family members. Let's say you have to stay at home in quarantine. Now you can't work. So now it's impacting your paycheck and your ability to provide for your family, right? So you can start to see how these things snowball and highlight the disparities in our community, not only from a healthcare perspective, but from an overall quality of life perspective as well. So we are seeing that in the Quad Cities, and we're working hard to try to meet those needs by pushing education and resources out into those communities. And we actually just had a couple of weeks ago a joint event with both Rock Island County and Davenport NAACPs in dispelling the myths related to COVID. So we were hearing a lot of misinformation about COVID in our community. Everything from it's a hoax, it's not real, to not wearing a mask is there's no impact there, to, I mean, just drinking alcohol can help with the symptoms of COVID. I mean, we were hearing a lot of different
for me.
different information that we were able to address in that event. So we'll continue to look at opportunities on how we can connect with the community to combat some of those challenges.
I have one more question related to COVID, and I want to make sure we spend a little bit of time on some kind of solution-oriented topics, right? And we've done a little bit of that through some of this dialogue, but I want to make sure we're intentional about creating this space for that. COVID-19 has obviously had an impact on the mental health landscape in our community as well, I would imagine. Are there any differences you've noticed with your clients, particularly your Black clients, due to COVID-19? Ebonie, I imagine families that are having babies and can't have relatives around, and that has a toll on that experience, and also mental health for those pregnant women and those families. But specifically, Dr. Stoner-Harris, can you shed a little light on what's happening in the mental health landscape as it relates to COVID?
Well, you know, we mentioned trauma earlier in the, you know, in this discussion. You know, what I've witnessed as a clinician, as a counselor educator, working with counselors who, you know, students who are training to be counselors, you know, people are feeling traumatized in the Black community. Stress levels are through the roof. And so whether that's, you know, kind of going back to those health disparities, or, you know, thinking about employment, or living in multi-generational homes where, you know, grandparents are, you know, a part of just a normal part of the household. And so they might be caregivers, and, you know, the concerns for kids going, you know, kids being in school, or kids being in daycare and coming home, you know, stress levels are high. And then, you know, the racial tensions in addition to COVID. What I've witnessed as a provider is, you know, African-American people, Black people are coming in into my office every day now. You know, like we're getting calls from, you know, referrals nonstop, you know, and when clients are coming in, they're talking about the impact. They're talking about the stress. They're talking about how they, you know, the depression, the anxiety, how they can't stop worrying about, you know, what's happening next, or how they're functioning in the workplace, you know, around non-Black populations, and the discussions that are taking place, and how that adds to the stress and the feelings of the experiences of trauma. And so it's a compounded issue. There are multiple layers to it. So it doesn't just become an issue about COVID. It becomes, there are layers to it. It becomes a larger social issue when you start talking about COVID and the impact that it has to people's lives, and the isolation, and we're a collective culture. We love being around our people, and people are struggling in our community to not be able to spend time with family members, to not have those social gatherings that are held on a regular basis, just stopping by people's houses, funerals. We're losing more people in our community, but we're not, the ritual, the homegoing of loved ones doesn't feel the same for people, because they either can't go, they have to watch it televised, or they're scared of, that they may end up ill. And so, yes, the trauma is how I describe it. It looks different ways for different people, but that's the result, is that people are feeling traumatized. People are, depressed and anxious and not knowing what's next.
Definitely. And not to take away from those comments, because I think that collectively, we as Quad citizens, we as Americans are that's a shared experience, right? We're all experiencing it on some level. But I will point to, using kind of my experience with some of my friends who don't come from the Black culture. I might say this person is my cousin, and they might be 4 or 5 generations down the line, right? But we grew up as siblings, even in some instances. That's how close we were. So the multi-generational and intergenerational dynamics of our culture isn't always shared across other cultures, right? Now, there may be, some families that operate in that way, but certainly my cousin, who I can't count how many lines down the road she is for being my cousin, who's like my sister, not being able to be with her, and then all the generations in between there, right? Just compounds kind of that experience. So I want to just shift gears and make sure we offer our listeners an opportunity to kind of glean from your experiences, to think through what would be some potential solutions and opportunities for us. We have about 5 to 6 minutes left here before we wrap things up. And so as best as you can and as succinctly as possible, just kind of shed some light for me on your perspective of what will it take for change in our community to happen to close some of these healthcare disparities? What are some of the first steps that we need to take to make sure that the next generation doesn't have the gaps that we have in health and wellness right now? I'll start with you, Dr. Stoner-Harris.
I would just say we have to be intentional when we talk about representation. We have to be intentional in our recruitment, but also our retention of Black providers, Black healthcare workers, and, also intentional in creating those safe spaces, even when the provider is a non-Black provider. And so again, back to the trainings, the cultural sensitivities, the cultural awareness, and being able to have those honest conversations with colleagues, with peers, when you see a lack of cultural competence and cultural relevance taking place in the setting, being able to have those conversations and not turning away and not addressing it. And so, we have to be more intentional, with creating those spaces where clients, customer, or patients will feel comfortable coming in and knowing that, they're receiving optimal care, just like anyone else would.
Right. What would you say to a person in the community who maybe doesn't identify as being a member of the Black community, but wants to make a difference or have an impact based on the information we've shared? Daniel, what would be something you would say to someone in the community who says, I didn't realize this, or maybe I was kind of aware, but now I know. What can I do to have an impact? Where can I make a difference?
Yeah. So now that you're aware, right, help share the information. help get the word out about some of the disparities that we're seeing in our community, and bringing those to light, and then figure out how you can be a part of the solution. I love what Dr. Stoner-Harris said about being intentional about our efforts. So now that we've collected some data, now that we understand what the gaps are, now let's work together strategically as a community to begin to tackle some of these issues. So that's what I would say from an individual community perspective. And then just to back up a little bit and add to Dr. Stoner-Harris's comments before, because I think she did a great job of covering it from a provider perspective. From an individual in the Black community, if you couldn't tell, I'm high on responsibility and personal accountability. I think there is some level of accountability in having us as Black people take our healthcare seriously. You know, finding an advocate like Dr. Stoner-Harris, finding a doula like Ebonie is extremely important in making sure that we have access to resources in our community. I've shared this with others in the community as well. And I said sometimes we do a better job of caring and taking care of the maintenance of our cars than we do our own bodies, right? We go and get an oil change, get our tires rotated, get new tires in order to make sure that our vehicle is running properly so that we can get from point A to point B. But we don't always do a good job of that with our own bodies and making sure that we're maintaining strong bodies to be there to provide for our families, support our families, and be a good person in our community in that way. So I'd also like to add that piece as we close this out, is just to make sure that we're doing our part, as well as trying to work together to solve some of these issues.
I really appreciate those remarks. I think you referenced it even in terms of exercise earlier. And I've seen in our community over the course of the last couple of years, there has been kind of a couple of different movements with like Black Girls Run and other organizations that create that sense of community that allow you to get out and be active. That is free. It doesn't cost to take a walk. There's also kind of the myth that eating healthy foods cost substantially more. I see that our farmers markets are taking all forms of payment at this time and that type of thing. And so there's definitely things that we can do on the individual level. We know our family's histories, even if we choose not to share it. You know when you're not well. And I think that while there is a lack of trust in some instances, there's also an opportunity to overcome that fear. And I think about a relative of mine who went into the hospital and went into the emergency room and, 12 days later died of colon cancer. You weren't well. You weren't well, and you hadn't been well for some time. And so you have agency. We Black folks, all folks, but we're talking about Black folks today. We have agency over our bodies. And when you're not well, and we have to overcome those fears and have those conversations so that your children and the generation after that don't have the same experience. And we have to be prepared to partner with those advocates for those things that we don't know. I can think of, and then I'll make sure you get some time in, Ebonie, but I'm kind of moved by these remarks because I think about how my mother supports. She was a first generation college graduate in her family, well-educated, speaks well, can connect with all different types of populations. That's not necessarily the case with her siblings, but she will go to a doctor's appointment with her brother. He's asked her to, so that he has a better understanding and there's not that disconnect in communication. So just as much as we would like our providers to have cultural competency, when we know where we're lacking, you come alongside with somebody who can fill in that gap so that we can be well. So thank you for those remarks about personal responsibility and steps that we can take. Ebonie, I want to make sure you have the floor to chime in on, not just the healthcare in general, or excuse me, not just pregnancy, but also healthcare in general. What are some of your thoughts about solutions to address the disparities?
I think that it's important that you speak up. Have the strength to ask the question. If you don't understand the answer, ask the question again. Mm-hmm. Get a second opinion if you need to. Just because one person says it's blue doesn't mean it's blue. Make sure that when you leave your appointment each and every time, you have a clear understanding of why you were there, what's the end result. You shouldn't need a whole bunch of extra follow-up, right? You should never leave an appointment and be like, I have no idea what just happened. Know what's happening with your body and have responsibility to yourself, as well as your family, to speak up and be encouraged to share your testimony or share your experience with a provider. And if you are ever in a situation where you don't feel comfortable with a provider, you have the right to change providers. I feel like oftentimes people feel like, okay, I've been seeing this person for a year and I've been uncomfortable for a year, but I have to stay. No, you don't. You don't ever have to stay somewhere where you're not comfortable. So that from my perspective, that's a big one, is to make sure you are with someone that makes you feel heard, that values your time and your words in your life.
Yeah. Thank you so much. Thank you to each of you for sharing your opinions, your expertise, your time. Is certainly appreciated as we dig into sometimes very difficult issues, but definitely conversations we need to be having on a personal level, but also with other people, so that there's awareness in our community. I want to thank our guests who have joined us, but also our audience who is online with us. We look forward to being able to connect with you next month. I think we're looking at November 12th, where we'll be working with some Black veterans as we are rounding the corner on Veterans Day next month. And so we're excited to be able to share that conversation with you. And we look forward to having you and anyone that you invite participate in these dialogues. And again, thank you to our speakers, and we look forward to connecting next month. Thank you.
Thank you for joining us this evening for Hidden Conversations. The Hidden Conversations project is coordinated by WVIK and organized by Tracy White, Dr. LaDrina Wilson, and myself, Jared Johnson. We have also been advised by Dr. Lauren Hammond Ford, Ryan Sadler, and WVIK's Intelligent Conversations Planning Committee. This series of Hidden Conversations is scheduled to culminate with WVIK's Intelligent Conversations event on March 11th, featuring former NPR host and current Washington Post contributor Michelle Norris, where she will discuss her books, The Grace of Silence, and the forthcoming book, The Race Card Project. We hope you are able to join us for all of these important and meaningful conversations.